Okay. Hello everyone. Welcome to ADIS webinar. It's Abhinav from ADIS. It's my pleasure and honor to welcome Dr. Wendy Thompson from Leeds, UK, who will present us about the drugs one work treating the emergency of dental patient. Welcome, Dr. Wendy. You shall start.
Thank you very much. Good afternoon, everybody, or good morning, depending on where in the world you are. My name is Wendy Thompson. I'm a dentist, general dental practitioner in Leeds, England. It's in the north of England. I have various roles, so I thought I would give you just a bit of a flavour of them.
Excuse me, Dr. Wendy. You have used your mic wrongly. Can you please open the mic if you can hear me? Hello. I don't know what's wrong, but you suddenly got muted. Dr. Wendy, if you can hear me, please try to unmute your mic yourself. Okay, I will try to show you how to do this unmuting. Okay, here you can see there's an option at the top bar. I'm sorry, there's an option, yeah.
This one, try that. Has that helped?
Yeah, so we can hear you now. I'm really sorry for this.
That's okay. I will start again. Oh, that's made a very pretty screen.
Okay. So you shall start now.
Let me start again. I'm sorry, everybody. Good morning, good afternoon, good evening, depending on whereabouts in the world you are. My name's Wendy Thompson. I'm a general dental practitioner from the north of England, and I am really pleased that you invited me to talk to you today. I wanted to give you just a bit of a flavour of where I work, so you have an idea of the breadth of what I'm doing. So I'm doing a PhD at the University of Leeds. I work as a general dental practitioner for a large corporate provider of dentistry in England. I provide out-of-hours dentistry in a very rural part of England. I'm on the British National Formulary Dental Advisory Group, so that's BNF if any of you use it for your prescribing guidelines. I provide lectures like this for Health Education England. Oh, that was interesting. And what was the other one? And I am on a NICE specialist advisor. NICE is the organisation in England which provides evidence-based guidelines. The aim of talking to you today is to talk about antibiotics prescribing, resistance and stewardship. And I hope in doing so that you will be more confident about diagnosing and treating urgent dental conditions by the time we finish. Some of them may need antibiotics, a lot won't. And giving you an update about antibiotic resistance and the fact that it's a growing problem around the world, which places ourselves, our family, our friends and our patients at risk. It's very timely, and I'm sure it's no coincidence that I'm talking to you this week. It's the World Antibiotic Awareness Week, which finishes tomorrow. Not just in dentistry, it's across all areas. In fact, let me go on to the next slide. No, not the next slide. There's one coming up in a few slides talking about One Health. Okay. The next slide, when people need antibiotics, they need them to work. And the reason that I'm talking to you today and the reason that we're interested in making sure that antibiotics are used when they're needed, but not used when they're not needed, is that we need them to work for people like this. People with Ludwig's angina, that's a life-threatening condition. And if antibiotics don't work for them, if this patient has a resistant infection, then there's not much more that we can offer these patients at that point. And it's a dreadful situation to be in, and it's increasingly happening, unfortunately. Antibiotics are essential for modern medicine. They're not just about treating infections, but they're about making sure that treatments like cancer treatment, joint replacement treatments, organ transplants can go ahead. Also about there's increasingly problems with treating of sexually transmitted diseases which are resistant to antibiotics. If a baby has to be born before time, it's preterm, it's really important for both the baby and the mother that the antibiotics are available to them. Wound infections, clearly, we all recognise this as being important. Urinary tract infections is, certainly in the UK, I'm not certain about around the world, is a large user of antibiotics, as is pneumonia and blood infections. So really, without antibiotics which work, modern medicine will look very much like it used to look before the Second World War, in the early part of the 20th century, rather than what it looks like now in the 21st century. So the World Health Organization has an action plan, and it's got these 5 bullet points. I'm not going to read them through, but you have them there. And I'm looking in particular today at optimizing the use of antimicrobial medicines, or in particular for dentistry, antibiotics. That's antibacterial medicines, because in dentistry, that's what we use most often. This is the One Health slide, and I was really pleased to see on your Twitter page that you have a One Health link as well to this presentation. I was trying to find the same graphic to put on the slide. I'd actually already chosen this one because I thought it just looks at it from a slightly different perspective. It's saying that antibiotic resistance affects humans, it affects animals, and it affects the environment as well. You know, when a human takes an antibiotic or when an animal takes an antibiotic, about 80% of it goes straight through the system unchanged. And it goes straight through you and out into the toilet and out through the sewage system and out into the environment. And then it affects wildlife and it affects our whole environment. It affects our way of life more generally. So this isn't just about reducing antibiotic prescribing in dentistry. In the scheme of things, we're relatively small, but we do have our role to play as well. So in Europe, we have, I think it was issued last week or the week before, a set of antimicrobial prescriber competencies. And these are split into 3 key areas. And I thought that they would provide quite a nice structure for today's talk. So that's what I've done for you. So they talk about the core concepts underpinning the whole issue. So that's microbiology, pathogenesis, and diagnosis. And then talk about antimicrobial prescribing specifically, and then talk about something called antimicrobial stewardship, which some of you may have heard of before, but some of you may not have done. Stewardship's it's a concept. It's about setting the environment, the clinical environment in which you're working, in such a way that it makes it easy for you to do the right thing. It encourages you to do the right thing, to only prescribe antibiotics when people really need them, and to conserve those antibiotics when they don't. And in providing that environment and in conserving antibiotics when we can, it means that they will be around for longer than they would be otherwise. So this is the first of those areas. And I'm going to tackle microbiology and pathogenesis first. So you all know that humans and animals are covered in a microbiome as part of our natural mechanism of keeping us healthy. We're covered in bacteria and fungi and viruses. Whether we're covered in prions is an area of research at the moment. And within our gut, the GI tract, gastrointestinal tract, the microbiome is particularly important. And again, this is an area of cutting edge research where they're showing that it's linked to obesity and type 2 diabetes. And there was even a study I read recently that links it to happiness. And if we change the gut microbiome by taking an antibiotic into the mouth and it works its way through our system, before it leaves the body, it's in the gut. And there are many studies now which show that the antibiotics change that gut microbiome for different periods of time. But for something like clindamycin, it can be a year or more that it completely decimates, really, the diversity of the microbiome in there. And the research to understand the impact of that is very much an important area of research at the moment. So the oral microbiome in particular, because we're dentists, it's what we're really interested in. And you all know that this is a very mixed microbiome, and it's also very stable as well. You can disrupt it, you can change it, but then it very quickly for each individual goes back to what's normal for them. So again, it's a mixture of bacteria, fungi, viruses, and I've given you a list there of some of the many bacteria which are in there, and which bacteria are present for an individual is influenced by the local environment. And you will know this as dental students, because if you have a patient with a dry mouth, you know that they're more likely to have a candidal infection, that they're more likely to have dental caries due to some of the streptococci that are there, due to the reduced flushing of the bacteria because there's less saliva to move it around. If someone's eating a lot more sugar, then they're likely to have a lot more caries from the acidogenic bacteria that thrive in there, and therefore the pH levels also drop. And you know that by encouraging someone to have more fluoride in their diet, in their oral hygiene routine, or if there's fluoride already in the water supply in your area, then the caries rates are affected because the fluoride affects the microbes and the microbial metabolism. Genetics of the individual as well. One of my supervisors at university has saliva which is being tested as having super buffering capacity, which means that she can drink as much Diet Coke as she likes and it doesn't appear to affect her, whereas the majority of the population don't have her strong genetics in that respect, and the acid would affect much more you and I than it maybe would do her. And an individual's immune status is also important. You know that if you have a patient whose immune system is low, maybe they're going through treatment for cancer, they've become immunocompromised, that they're more susceptible to infections than again, the average patient. Just looking for a moment at the picture of the Petri dish that I've shown you there with lots of different colonies growing on it. It's worth remembering that the vast majority of bacteria will not grow on a Petri dish. So although you can plate up a little bit of your saliva or a swab from within the mouth somewhere, it will only grow the things that like growing in a lab environment on a Petri dish. And just because something grows on a Petri dish in a lab environment doesn't mean that, say it came from a dental abscess, it doesn't mean that that's what is causing the problem within the dental abscess. It just means that that's what will grow. And there are other techniques based on DNA, which allow a much wider sampling, but it's still quite difficult to understand which of those very many bacteria are the ones causing the problem. Dental infections are usually polymicrobial as well. And you'll recognize this progression really. So on the first tooth, we have a small amount of decay in the occlusal surface, and you would hope that if someone's attending for regular dental checkups that you would pick that up and be able to help them arrest the progress of that and maybe treat it with a filling. And then in the second diagram, the patient hasn't been to see you or hasn't accepted the treatment that you've offered, and the decay has progressed on. It hasn't reached as far as the pulp yet, but it's in the dentine and it's causing them quite some pain. This would be irreversible pulpitis by the time it gets really close to the pulp. And then in the final slide, the decay, the bacteria from the decay have got into the pulp, and that's a nice rich environment, lots of tasty things in there for the bacteria and the bugs to eat, and they quickly form an abscess, which is the body's immune response. The macrophage is trying to get rid of the infection that's there, and the abscess forms, and that's the point at which we start thinking, do we need an antibiotic or not? Sometimes people might think at this stage, do I need an antibiotic or not? But obviously there's no bacteria actually into the pulp at that point. So there's no infection here. It's here where the infection occurs. And as we'll talk as we go through, usually you don't need an antibiotic, because usually if the patient comes to see you at this point and the infection hasn't spread beyond just a localized abscess, then you open the tooth up, you wash it out, and you can do a root canal on that treatment, on that patient, endodontic treatment, or you can take the tooth out in its entirety. Oops, sorry, go back. So our immune system, I've mentioned a few times, and it's really important to all of us. It keeps us in balance. The flora is that microbiome, if you like. It's all of the bugs that live on us. And it's only when the immune system becomes overwhelmed that antibiotics are really important for us. And it might become overwhelmed because it's a really virulent infection, or it might become overwhelmed because the immune system isn't working completely properly, or a combination of the two. But the most vulnerable patients within our patient base are immunocompromised patients, so those who are going through cancer and transplant treatments, who've had their immune systems knocked out on purpose for the sake of doing these advanced treatments. And so they need the antibiotics to work. If antibiotics don't work for them, going back to what we said right at the beginning, it's a very, very difficult situation for them to be in. So this cartoon I've got down on the right-hand side here for you is well, you can imagine it to be whatever you want it to be, really. You could imagine it to be a Petri dish like we had on the previous slide, or you could imagine it to be a dental abscess, or it could be a small patch of nasal mucosa, or it could be a patch of skin on your arm. But what I'm showing is that there are lots of different bugs on there, and they have different, they're of different types. And if I put antibiotics onto that Petri dish, or whatever else you think it might be, if there's antibiotics there, then the only thing left to grow, is the one that's resistant. And that's natural selection. You know this from your basic biology lectures. And then once you've got a resistant bug there, the only thing that's now left to grow is the resistant one. And so you've gone from a mixed culture, which is normally stable, to a monoculture, which is usually much harder to treat and to sort out. And so if you have a patient with a dental infection and you give them an antibiotic and it calms things down, so the patient disappears off for a couple of years and then comes back to see you again, hopefully an antibiotic would work again, although hopefully they would be accepting the operative treatment from you, the procedure. But if they don't, and if they keep having an antibiotic, you can understand that the risk of it becoming a resistant infection, and therefore much harder to treat, in fact, becoming impossible to treat at some point, increases. Resistant strains, though, don't usually cause a problem in healthy people. They're just one bacterium amongst many bacteria. And Clostridium difficile is just one of these things, one of these bacteria. It lives in the gut, it's anaerobic, and it can cause a really nasty colitis, a really bloody diarrhea that is on occasions fatal, especially amongst older people and people with who are already quite ill. But notwithstanding, it has been recorded as being fatal for people who are fit, healthy, young, and if you Google search it, there are many examples in the literature, or increasing numbers of examples in the literature, of people passing away from an antibiotic related colitis from C. difficile, which resulted from having an antibiotic. And it seems that the antibiotics particularly associated with it are coamoxiclav, clindamycin, cephalosporins, the third generation, and ciprofloxacin. In the UK, we don't advise dentists to use coamoxiclav or clindamycin, well, any of those, but those would be the two that often dentists from other parts of the world might use. But in the UK, we strongly advise against it, unless there are very specific reasons. Maybe the hospital has done some culture and sensitivity testing and recommended that those are the antibiotics to be using. Okay, so Clostridium difficile, the way it works, if you remember, let's just go back to this diagram. If this is your gut microbiome and we put antibiotics in there, because Clostridium difficile is an anaerobe, it doesn't respond to the same antibiotics that aerobes respond to. So if all of the aerobes are wiped out of the gut, the thing that's left is the anaerobe, the Clostridium difficile, and that's what's left to grow. And the reason I've put a picture of someone having Botox on there isn't because I've gone nuts. It's because Clostridium difficile and Clostridium botulinum are very closely related bacteria. Both of them are anaerobic bacteria, and when they grow anaerobically, they produce a toxin. And Clostridium botulinum produces Botox, which we inject into people's faces. Some dentists do it, some therapists do it for aesthetic reasons. And in the gut, the Clostridium difficile also produces a toxin which paralyzes the muscles. It has a range of other effects the way it works, but that's what is the basis of the diarrhea that's caused, the colitis. So if there's a Clostridium difficile there, you wouldn't know in advance because it's one of those things that's in some people and isn't in others. But if it's there, and if it's the one thing that's left, and if you are unlucky that it's your patient, or if your patient's unlucky to have it, and you've given them an antibiotic that you would do normally for anything else, and any other day of the week would be fine, you can end up in a very serious situation with that particular patient. So this is the reason that in the UK, we don't advise coamoxiclav or clindamycin. To be fair, it can also happen with amoxicillin as well, but it seems to be less frequently. How do bacteria become resistant? I'm rather hoping you've probably already done some of this in your undergraduate degrees so far. But if not, I will just go through it fairly quickly. So bacteria become resistant because they get proteins which mean that they can deal with the antibiotic in a way that normally they wouldn't do. So it might be that they've produced an enzyme which can work in a new way, or a protein pump which can pump it back out again. And on the next slide, I'll show you how those proteins might work. But the proteins are coded for by genes, and the genes are on our DNA. And so the way that bacteria become resistant is because they get new DNA. Now, that might be a spontaneous mutation. It might be one of the base pairs within the DNA spontaneously mutates for no apparent reason. And there is a spontaneous mutation rate. We all have it. Usually they make changes which make no difference to us at all, but sometimes they confer a different phenotype on us. And sometimes the DNA is acquired from another bacterium. Maybe that bacterium is already resistant, and so if it passes a resistance gene onto the new bacterium, it doesn't need to be of the same type, then it can actually confer resistance to them. And then the selective pressures, which we've talked about, the natural selection, then allows that particular bacteria with that new DNA in it to become more competitive than the strains which aren't resistant. And so if there's antibiotics in the environment, it selects for the resistant strains, and so they're the more likely ones to be able to reproduce. So this is talking about the proteins. So where's my cursor gone? There we are. So it could be degradation or breakdown. The antibiotic here is taken into the bacterial cell, and it finds the enzyme that can break it down, and it breaks down the antibiotic. So this enzyme means that the antibiotic can't work, and this enzyme is coded for by the DNA. Or it could be that there is an enzyme which deactivates the antibiotic. So this antibiotic comes into the cell, and a different enzyme then produces a different form of the antibiotic, which can't, again, kill the bacterium. So again, it can't work. Or there might be an efflux pump. So there can be a protein that embeds itself into the cell membrane, and when the antibiotic's inside of the bacterium, it then pumps it straight back out again. So it doesn't have time to kill the bacterium. Okay, so there's different ways. Those are the three key ways in which bacteria resist antibiotics. And the mechanism for doing that, as I've said a number of times, is that they're coded for on DNA. And DNA, this isn't to scale, that bacteria have got a big mass of DNA. It isn't organized in the same way as in a eukaryotic cell. These prokaryotic cells have a massive tangle of DNA, which is actually relatively difficult to pass from one bacteria to another. But they also have these small rings or plasmids of DNA, and these are very easy to pass around. And when I did my microbiology degree back in the early 1990s, we used to use plasmids of DNA like this with antibiotic resistance genes on there. Then we could know they would have another gene on there, which was our gene of interest, and we could know where we'd passed that whole plasmid onto in order to then get the bacteria to express the other gene that we were looking for. So resistance genes are often on plasmids. They're often easy to move around between different bacteria. And that can happen in three different ways. The plasmid can pass directly from one bacterium to another bacterium, and that's called horizontal transfer. So you can see here, you've got one bacterium, it's come together with another one, they've conjugated, and the plasmid has just passed from one to another. or it can be transformation. So you've got a healthy bacteria here, and you've got a dead and dying bacteria here, whose DNA is being released because the bacterial cell wall has been breaking down. And that DNA from the plasmid can then just be absorbed like a sponge into another bacterium that's there. So this bacterium goes from being not resistant to being resistant. And transduction. So you have a virus here, and the virus can take in DNA from one bacterium. And then when the viruses are released, the bacteriophages are released. They go and find another bacterium and squirt the DNA into it and make this bacterium resistant, if it was a resistance gene that was on there. This happens with a whole load of DNA. It's not just DNA which confers resistance. It could be all sorts of different attributes that it could be passing over. And this is a technique that is exploited by scientists that I was referring to earlier, when they want to move DNA from one cell to another to insert specific genes. Okay, some of you will have seen patients now, I assume. Some of you may not have done, but I'm sure we've all been in the situation where we've heard someone say, I've got toothache, I just need antibiotics. Not, please may I have, or I'd quite like. It's, I really need, I just need antibiotics. And that's a really difficult conversation to have at that point, because they're in pain. They're frightened, scared of what's going on, what the implications will be if they don't get sorted out. They might be scared of dentists generally. And if you're saying, actually, you don't need antibiotics, what I need to do is a procedure on you, that may make them even more scared. So these are high pressure situations to be in, and your communication skills in terms of explaining to the patient what's going on and what needs to happen to sort them out and get them out of pain and to reassure them need to be absolutely top notch at this point. So if you remember those 3 bullet points I gave you at the beginning about the European prescriber competencies, diagnosis was really important. And diagnosis of acute dental conditions, there is a document which I'll refer you to. It's the Scottish, I'm English, but Scotland's our friends. Scottish Dental Clinical Effectiveness Partnership have produced some really, really good guidance on a whole range of things. And if I can encourage you to go and have a look at their website, I would definitely do so. It's got all sorts on there about acute dental problems, drug prescribing for dentists, also things like bisphosphonates. How do you deal with a patient who you're worried about who may get bisphosphonate related osteonecrosis, those sorts of things. So in this particular advice booklet, they identify a range of acute dental conditions, and the key ones for us are acute periapical abscess, acute pericoronitis, acute periodontal conditions, dentine hypersensitivity, pulpitis, and alveolar osteitis. And I would suggest that these are the ones you're probably most likely to see in practice when someone turns up for an emergency appointment, for an urgent appointment. And why have I put a gap here? Well, I'm sure you've recognised that the bottom ones are definitely not infections, and the top ones may be infections, or they may not be infections. But let's talk about the definitely not infections at the moment. If a tooth is vital, if it's very vital, if when you put cold air on it, they jump out of the chair, the nerves on the inside of that tooth are working. They're working very, very much. But if the nerves are working in there, it's not infected. And there's no pus in there because that nerve's still alive. And so no antibiotics are appropriate for that tooth. It's an inflammation. Dentine hypersensitivity, reversible or irreversible pulpitis, and alveolar osteitis, or dry socket by another name, are inflammations. And the treatment for those is analgesics and remove the cause of the pain. And the analgesics that we recommend in the UK are paracetamol and ibuprofen. I haven't specifically given you any doses on here because in each of the different countries that you're from, you may have different prescribing guidelines. So I'm going to tell you what we do in the UK. And then you need to go away and find out what happens in your own country, what your guidelines are. In the UK, and I know in America as well, the guidance is that opioid analgesics don't work for dental pain any better than ibuprofen and paracetamol taken together. And opioids have the risks that go with them So we stick with just paracetamol and ibuprofen. And you, traditionally in the UK, we taught dental students to alternate between ibuprofen and paracetamol. And what we found was that patients were starting to get confused. When you're in that much pain with toothache, you can't quite think straight. And actually, we started looking at whether guidance that said take them both together at meal times, so 4 times a day, breakfast, lunch, dinner, and before you go to bed at night, whether taking them together helps in those respects. And it seems that taking them together may have some benefit compared to taking them alternating. So I've given you now the evidence base on these slides for each of the conditions that I told you was an inflammation and why antibiotics don't appear to reduce the symptoms for them. I am not going to go through those in detail. You have these on the slide now. I assume you know that Cochrane are a database of systematic reviews which have been done in a very, very careful way to make sure that the evidence-based guidance or evidence-based dentistry is based on the best research that's available. So irreversible pulpitis, antibiotics do not appear to reduce toothache caused by irreversible pulpitis. Next slide. Acute apical or radicular periodontitis. So at this point, the tooth has died. The nerve on the inside of the tooth is not working anymore. So you put cold on it, they can't feel it. You can drill into the tooth and they can't feel it because there is no nerve in there. And what happens is before it's become an abscess, so it's just an empty tooth. So when you drill into it, you can wash it out, you can dress it, or you can take the tooth out. And there's no clear difference in the pain or swelling reported by participants who received antibiotics compared with a placebo when done in conjunction with the first stage of a root canal treatment and painkillers. An alveolar osteitis or dry socket is often incorrectly called infected socket. Certainly on the UK dental records, the electronic dental record systems, very often the button that you click to say that that's what you were treating, it says infected socket, which kind of encourages you to think that maybe an antibiotic might help. But actually dry socket is an inflammation and it's caused by the clots not forming properly in the socket after you've taken out the tooth. And the treatment for it is to wash out the socket using saline. In the UK, our guidance is not chlorhexidine anymore. We've had a few more than unfortunate occurrences, and people have ended up with anaphylaxis to the chlorhexidine that was being used to irrigate and have died as a result of it. So we now recommend irrigation with saline, and then dressing with something like Alveolar, although there was a Cochrane study that said it didn't matter whether you dressed or not. What you really need to do is get rid of that clot that hasn't formed properly and that is degrading within the socket, and that's what's causing the irritation of the nerve endings in the bone and giving the patient so very much pain. And optimal analgesia is really important for these patients. So it's one of the most painful things that they will get. Acute bacterial infections. So at this point, it's a natural infection. So an antibiotic might be considered. But actually, if you can establish drainage and remove the cause of the infection, then you don't need to give an antibiotic at all. If you remove the pulp, extract the tooth, clean out the infected periodontium or underneath the operculum around pericoronitis. As long as the swelling and the symptoms of the infection haven't become systemic, so the swelling isn't going towards the eye or the throat, you're not worried about it closing the airway, or there's no increased body temperature, which might suggest sepsis, or if the patient can't open their mouth because they've got trismus, you need to do something more because they need to be getting better, and if they can't open their mouth, they're going to be getting worse, not better. Lymphadenopathy, that's a sign that the infection is spreading down the neck. And if you've tried to do local measures, you've tried to remove the pulp from the tooth, but you just didn't get any pus draining from it, and you're just not certain what's going on, or you've already done all of those things and the patient's come back and the swellings continue to get worse, those might be cases for antibiotics. But generally, the vast majority of occasions, if you remove the pulp, extract the tooth, and clean out around it, there's no need for antibiotics at all, because what happens is you get rid of most of the infection, and then you dress it, where if you've extracted a tooth, the socket heals up, and the immune system, the body's immune system, goes along and it cleans everything else up for you, any remaining bits of infection. So antibiotics also, they're not an alternative to appropriate measures. So even if you think, yes, antibiotics are needed for this patient, you should always try and remove the pulp, extract the tooth at the same time as well. So just a few pictures. Oh, I'm sorry. That's my daughter trying to call me. I thought I'd switch that off. This is a tooth that I extracted, and I saw the nice abscess on the end of it, and I asked the patient if I could have a photograph of it, which he thought was rather strange, but I explained that I provide lectures like this, and so he was, of course, very happy to be able to help with the education of future dentists. So you can see the abscess there, and if he'd wanted to save the tooth, if there'd been enough tooth left to save, I would have cleared this out, and I would have opened up the canal for him, drained out this pus, because this is under pressure when it's in the mouth, and if you just drill straight into the top of here without any local anaesthetic, because the patient can't feel it because the nerve's dead because there's an abscess on the end of it, the pus here will, the pressure will push itself up through the tooth, and you can wash it out, and the patient receives almost immediate relief. They're very happy patients, especially people who don't like local anaesthetic. It's a good result for them. Acute pericoronitis, again, isn't always due to a spreading infection. The aim is to drain and irrigate that infection, so to clean out with saline underneath the operculum here. Analgesics and fluids make sure the patients are keeping themselves hydrated and that they know which analgesics to take. And if there is a spreading infection, you know, these lower molars are really quite close to the corner of the mouth, which is quite close to the airway. You don't want an infection there spreading into any of those fascial spaces anytime soon. So antibiotics would be appropriate if you had signs of spreading infection, which, remember, is the temperature, is the swelling spreading towards the airway. Necrotizing ulcerative gingivitis is the third possible time when you might want to give antibiotics. Again, you only give it if the infection is spreading. Your mainstay of treatment is ultrasonic debridement, giving it a really nice clean. You can see the grey sloughing at the margins of these teeth. This isn't a particularly advanced case of it, but you can see there, and probably when the patient walks into the surgery, that this would smell really quite nasty. Sometimes they're smokers. The textbooks will tell you that they're almost always smokers, but the only cases I've ever seen are of students who have beautiful, healthy mouths, who've just got really, really stressed with their exams, and their immune system's done something strange, and they've ended up with necrotizing ulcerative gingivitis. And if the infection's spreading, then antibiotics are indicated. And of course, I showed you the picture of someone with Ludwig's angina early on, and this is the same thing here. If these soft tissues, actually the skin's quite thick soft tissue, so if these soft tissues are bulging and red, then you can only imagine what the soft tissues on the inside of the airway and the mouth are doing, because they too are being pushed under the same pressure as this. And that's why it's life-threatening, is because it will occlude the airway. And that's the treatment that they're provided with when they get into hospital. And I'm certainly not providing that for my patients in primary care. And I suggest you don't either, unless you're up against a wall and there's no other option to save that patient's life. So I would encourage you to recognize the signs of Ludwig's angina, of an orbital cellulitis, which risks going back into the brain as a brain abscess. So that's swelling around the eye is an orbital cellulitis. So swelling around the eye such that it closes the eye, and also sepsis, being aware of the signs of sepsis, because when we're working in primary care practices, it's primary care, and we need to recognise at which point they need to be seen in hospital settings. Because when people need antibiotics, they need them to work. And there is a balance between accessing antibiotics, having everyone who can access antibiotics, and restricting that access. Because actually, globally, more people die because of an infection than die because of a resistant infection. They die because they don't have access to antibiotics to treat their infection, especially so in low middle income countries. And that can't be acceptable. We need to make sure that people have access to high quality antibiotics and enough antibiotics to treat the causes that they have, whilst at the same time protecting against the development of resistance. And that's a difficult balance to get, isn't it? In the UK, you can only get it, well, you're only supposed to be able to get antibiotics through a prescription from a medical practitioner or a dental practitioner, from a qualified prescriber. But there are stories still about people being able to buy them through different ways that may not be quite appropriate. And in some countries, it's perfectly legal to go and buy antibiotics over the counter in a shop. And unrestricted access, people who want to go and get themselves some antibiotics and just using them because they feel like it's the right thing to do, that encourages resistance. So we need to make sure that there's rational use of antibiotics. And as professionals, as trusted members of your community, you have a really important role to play with your family and your friends and your patients and members of the public in explaining the risks of antibiotics as well as the benefits of them, and encouraging them to seek a medical opinion if they believe that they need an antibiotic. This graph, or this chart, sorry, is a few years old now. It's from 2012, and it's about MRSA, so that's methicillin-resistant Staphylococcus aureus. So not particularly a bug that bothers us for dentistry too much, but what it shows is the rate of resistance. And in the Scandinavian countries, where antibiotics are, the population tends to only want to have antibiotics if they really have to have them. There's not the same demand for antibiotics in those countries. Whereas in some of the more southern European countries, you might be able to buy the antibiotics over the counter. Certainly in Poland, I have patients in the UK from Poland who can buy them over the counter in Poland, and they will tell me that people expect them. They believe that that's what's going to sort them out. And they're quite surprised when they hear that antibiotics don't cure toothache, for example. So as professionals, we have a role in educating the public about the risks of antibiotics. And I'm not going to play you this cartoon, if you like, but it's a really, really good one from Canada. Canada has a Choosing Wisely campaign. It's their antimicrobial stewardship campaign. And as you can see, this particular one is about someone who's got a cold, but it goes through and it explains in lay person's terms, in patient terms, the risks, including Clostridium difficile, which we talked about earlier. Okay. So that's the end of that first section. So the next two are rather shorter than that first one. So antibiotic prescribing, and in particular dental antibiotic prescribing. In the UK, our main guidance is the British National Formulary. Some of you will probably use that as your main prescribing guidance as well, but many of you will have your own national guidance. And the Scottish Dental Clinical Effectiveness Programme has taken the BNF guidance and for dentists in particular, put it into terms which are much more easily accessible. So very many UK dentists will use the Scottish version to access the guidance from NICE, from BNF, rather than going direct to the BNF. And there's an app, and it's available for Android as well as for iPhones. And it's really useful and it's free. So if I can encourage you to download that, then I think that will be really a helpful thing for you. And they also have within this guidelines a flow chart about managing bacterial infections. And as you can see, it goes through the same areas that I've talked about: dental abscess, necrotizing ulcerative gingivitis, and pericoronitis. It also covers sinusitis, although there's increasingly evidence that we shouldn't be prescribing antibiotics for sinusitis, and that that really is something that doctors rather than dentists should be looking at. And actually, most of the time it's viral. And so I think I can't remember the percentage, 95%, something like that, of the time it's viral. So antibiotics aren't going to work for it anyway. If you wanted to prescribe something for sinusitis, ephedrine would be your best. A nasal decongestant would be your best bet for that. So the general rules that both the BNF and the Scottish Dental Clinical Effectiveness Partnership provide are that it's the things I've told you already. It's about draining and removing the source of the infection, and antibiotics only if the infection is spreading. And I've given you the UK antibiotic doses here. Our mainline first choice drug for a dental abscess is amoxicillin, 500 milligrams, 3 times a day for up to 5 days. And if you have pericoronitis, or necrotizing ulcerative gingivitis, then the first choice drug would be metronidazole, 400 milligrams, 3 times a day for up to 5 days. Now, if you can't give amoxicillin for the dental abscess, our guidelines say that we go to metronidazole. And if we can't give metronidazole for the necrotizing ulcerative gingivitis or the pericoronitis, then our advice is to go for amoxicillin. So as you can see, for almost every case, amoxicillin or metronidazole are the indicated drugs in the UK. And if you can't give either of those to a patient, then you would look at a macrolide. And my guidance to the dentist is always to go and have a look at what the latest guidance is, because things do change from time to time. And it's worth making sure that you're giving the latest guidance. And although these doses are adult doses, the age of an adult starts at about age 6, I think it is for them. It's really quite young. But again, if you've got a child, I would suggest going to the BNF and checking the doses. In the UK, we also have evidence-based guidance from the Faculty of General Dental Practitioners. And if any of you are based in the UK, then I would advocate you going and having a look at their website. It's free to access. It's just a little bit more, it's not quite so accessible as the BNF and the Scottish version of the BNF. The other bit of advice in all the guidelines is that we should be reviewing patients after 2 to 3 days. And if the symptoms have resolved after 2 to 3 days, then we should stop the patient taking the antibiotic, because we don't want patients taking antibiotics for longer than they need to, because all the time they're at risk of something happening to them from the antibiotics and also to the environment, because if those 80% of those antibiotics are going through them unchanged and out into the environment, then that's a selective pressure on wider antibiotic resistance as well. So where are antibiotics prescribed? So in England, this is from NICE. Do you remember I talked about the NICE organisation which produces our evidence-based guidelines? And GPs, general practice doctors, are responsible for about 3/4 of all antibiotics across the National Health Service. National Health Service is the government-provided healthcare sector that provides free at the point of use is the slogan, although dental patients do have to pay to come and see a dentist if they're not exempt charges. But it's the vast majority of people in the UK receive their medical and dental treatment through the NHS. So 75% comes from GP, so that's primary care. 5% comes from primary care dentists. And just a little bit more than that, 7% comes from hospital outpatients. And 11% comes from hospital inpatients. So actually 5%, when you think about the really few occasions when it's appropriate to prescribe antibiotics in dentistry, 5% is really quite high. And there was some research done a few years ago which suggested that there was about 80% over-prescribing among dentists. And that's kind of borne out because in the last 5 years, both in England and in Scotland, we've seen a 24% reduction in antibiotic prescribing by dentists. That's huge, 24% over 5 years. So it's a good effort, and it's I wouldn't say that there is any one particular intervention that's caused it. It's lots of pressure and everyone recognizing the reasons that we need to reduce and to optimize, whilst at the same time ensuring that we're not going to increase any adverse outcomes for patients. And very recently, maybe a month ago, the British Association of Oral Surgeons worked with the Faculty of General Dental Practitioners, and they issued some e-learning modules. I'm not certain whether you need to be from the UK to go through them, but if any of you are from the UK, you can certainly access them. And you have the web address here from BAOS. And then antibiotic stewardship. You remember I talked about this being the systems and processes that are put in place by the organisation to make it easy for you to do the right thing. And that includes public information campaigns. So this is from Leeds. Again, if you wanted to go and have a look at some of the material that they have, seriouslyresistant.com is well worth a look. Now, this was a global report that was produced in 2016. Jim O'Neill, Lord Jim O'Neill, is an economist. And you know that there's something important afoot when an economist starts talking about science. And Jim O'Neill led this massive review. All the papers are out there for you to be able to go and read. And what it says is that the pale blue sectors are the number of deaths from each of these conditions at the moment. So you see there 8.2 million deaths from cancer at the moment. But by 2050, so what's that, about 30 years' time? 10 million people, more than currently die from cancer, are expected to die from resistant infections. And that's massive. And that's what we're trying to slow progression towards by increasing the production of new types of antibiotics and by reducing overuse of antibiotics that are encouraging resistant infections to evolve and to spread. And I just thought we'd go back through history. Do you remember I just said that that's 30 years' time when we reckon there's going to be 50 million deaths? But actually 100 years ago last weekend, the Great War, the First World War, finished. And I was just looking for an image to show you just to make the point. And actually this came from the Imperial War Museum, and it was a global war. And I thought that was a really nice slogan for antimicrobial resistance as well. It's a global war. And 100 years ago, when we had this global war, there were no antibiotics to be able to tend for the wounded soldiers. And many, many soldiers died from infections. And this is Professor Dame Sally Davies, the UK Chief Medical Officer, and she's one of the people who's been pushing forward the global agenda on antimicrobial resistance. And as she says here, it poses a catastrophic threat. And she's likened that threat to global terrorism. And if we don't act now, any one of us could go into hospital in 20 years for minor surgery and die because of an infection that can't be treated by antibiotics. And unnecessary use of antibiotics is driving resistance. This is Alexander Fleming, not quite 100 years ago this time, 90 years ago this year. He wrote a paper. He came back from his holidays. He'd left the lid off a Petri dish that wasn't quite on, and he'd noticed that there was this zone of inhibition around his fungi, these fungus that had grown, and he called it mold juice inhibiting staphylococcus. And he wanted to know more about that and how that was working. Now, this is my friend Joseph. He's a very close family friend. And if you look at the year that he was born the year before Fleming had his accident with his bread mold. And Joseph was born, and he had parents, and his parents had parents, and they lived a life when there weren't any antibiotics. They lived in the pre-antibiotic era. And he's still knocking around now, and he was a doctor himself, so he's prescribed many antibiotics over the years. But this is making the point that he came from a pre-antibiotic era, and Dame Sally talks about us heading towards a post-antibiotic era at a rate of knots. So new antibiotics, you can see here we had sulfonamides for a start, but they're not really classed as antibiotics. You've got penicillin here, that was the first one. And although it was found in 1928, it wasn't until the 1940s when penicillin started, Florey and Chain found a way of producing it in a way that it could be used as a drug. And obviously the 1940s coincides nicely with the Second World War, and it was its development moved on very much more quickly as a result of that. And these are my parents, and they were born in 1942 and 1946. So again, pretty much pre-antibiotic. And here I am talking to you now, very much from an antibiotic era. In fact, interestingly, my degree in microbiology in the 1990s, if you go back to this diagram, was in here, the time when we had no new antibiotics coming forward. And the reason for that was because all the drug companies were focused on HIV medication at the time, trying to solve that problem. And then you can see that as things move forward, and they got the HIV just about cracked, they then started looking at more antibacterial drugs again. Professor Dame Sally Davies wrote a little book about her vision of a post-antibiotic future. And if you are interested, then it's well worth getting a copy of it. It's only not very expensive at all, a few pounds on Amazon these days. But going back to 1945, so the year before my mum was born, he won a Nobel Prize. So from 1928, when he first had his accident with his bread mold, to the 1940s, when it started being used for military purposes, through to 1945, when he won his Nobel Prize. And he said in his prize-winning speech that it's not difficult to make microbes resistant to penicillin, and it has been seen in the body. So we've known about resistance for a long, long time. And this chart's the same one that I showed you before, but instead of the top being when antibiotics were deployed for a start, the bottom line shows you when resistance was first noticed. So you can see you have penicillin from the early 1940s, and then resistance was seen only a few short years later. And you have erythromycin here that was first found in the early 1950s. And it lasted, of all the different drugs on here, this is the one that lasted longest until they saw resistance in the late 1980s. But in the UK, certainly, erythromycin resistance now is so high that we're advised not to use erythromycin. And so our macrolides in the UK that we use are clarithromycin or azithromycin. With it being Antibiotic Awareness Week, we have TV adverts on at the moment, radio adverts, and people who've known me for years and know that I'm doing work in antibiotics, which has felt like a very niche field, have suddenly started singing this song to me when they see me out and about. I'm not going to play it for you, but again, you've got the link there if you want to watch it. And it says, antibiotics don't work for everything. Don't ever think they're going to cure all of your ills. And patients are starting to get that message in the UK. I would encourage you all to sign up to become an antibiotic guardian. And when you click on this antibioticguardian.com website, it has people from all over the world now signed up to it. And you select whether you're a member of the public, whether you're a professional, whether you're a dentist, whether you're a midwife, whether you're a school kid, whatever it is, you select what you identify as, if you like, and then it will give you a series of pledges that you could make. So for dentists, I think it says, I pledge to think about providing a dental procedure rather than prescribing an antibiotic in the first instance. There's maybe 4 or 5 different dental options you can choose, or make your own pledge. And when you've done that, and when you've signed up to it, it's free to do. You then get a certificate which you can print out and you can display. And I encourage dentists to do that and put it up in their waiting room, because then it manages patient expectations before they get into the surgery. There's another poster here that we have in the UK right now. Taking antibiotics when you don't need them puts you and your family at risk. And again, this is about changing the public perceptions of antibiotics as being miracle pills. Traditionally, they've been seen as, people have found them quite comforting and seen them as being a good thing. And we're trying to just disrupt that thought pattern a little bit and encourage them to realise that, like anything really, there's risks and benefits, and they need to understand the risks that they're putting themselves at by using antibiotics when they don't need them. From the dental perspective, and this is our UK logo, if you like, antibiotics don't cure toothache. And we have an antimicrobial stewardship toolkit website, which you're very welcome to go and have a look at. If you Google dental antimicrobial stewardship, it will pop up as your first option. And on there, you can get access to posters and leaflets. This one is one of those leaflets that you fold into thirds. They're both printed out in A4, and then you can hand them out to patients. But I would just like to finish off really by just reflecting back again and thinking, going right back to the beginning of the presentation, the best way of preventing a dental infection or a dental abscess is actually to prevent that decay from moving anywhere in the first place. And the best way of doing that is with a toothbrush, and in particular with toothpaste, because fluoride helps prevent tooth decay. And it's also about encouraging patients to reduce their sugar intake in between meals. I don't know whether any of you have ever done a project like this, but we often get our dental students in the UK, and dental nurse students as well, to produce a display about sugar and looking at the different drinks. You know, this is a milkshake. People often say, oh yeah, I drink milk, I drink lots of milk. They don't realise that a very large percentage of that milk is actually sugar. And then you go down and you see how much sugar is in these tins. And if you ask them to eat it with a teaspoon or a spoon, they'd very quickly get to the point where they couldn't eat anymore. But because it's in a drink, they're drinking lots of this stuff, and it's they're sipping it all the way through the day, and the acids may be in there as well as softening the teeth at the same time. So in terms of reducing antibiotic use, it's about encouraging good oral health. And in clinics, and again with your patients as well, it's the general infection prevention and control messages. So hand washing, changing gloves when you're in clinic, PPE. And then I was asked just to reflect as well on what would work best for you in your countries, what top tips for you. And really, through my research, I found that there is so much variability in what influences why people are prescribing antibiotics that you really need to look at what the issues are in your own context. So in the UK, we've done work with general dental practices, we've done work in out-of-hours dental surgeries, we've done work with oral surgeons in hospitals, and they all have their own specific cultures and reasons why antibiotics are used more or less in some areas. So I would encourage you as students to think, if you have the opportunity to do a project, to find out what's already known about the extent of antibiotic misuse in your country and what are the reasons for that. Because if you don't know that information which underpins it, then you can't really work out what the best way to reduce it is. So the kinds of questions, I was just really having a think about, if I was you, what I would be wanting to know. So what are antibiotics being used for in dentistry in your country? Are they being used to treat urgent conditions, or are they being used as surgical prophylaxis? So, for example, if someone takes a tooth out, do they automatically give them an antibiotic just in case they might get an infection? Or are they being used to treat the acute conditions like we've just been talking about earlier in this presentation? Also, how do people access medical and dental services in your country? Is it easy? Is it expensive for them? How does the cost of accessing an actual medical appointment fit relative to other parts of their lives? I was out in the Philippines earlier in the year at the Asia Pacific Dental Congress, and they were telling me that it costs the same, 1 day's worth of antibiotics costs the same as 1 day's worth of meals. And that's quite difficult, isn't it? You're saying to someone, I want you to take antibiotics for 5 days. You're effectively saying, I don't want you to eat for 5 days. And that's not ideal if you want someone to recover from an infection, because you want their immune system to be fit and healthy as well. So it's understanding your context in that respect, and then how easy it is to get hold of antibiotics. Can they be bought over the counter? Can you reuse antibiotic prescriptions? Again, in the Philippines, they told me that they were given a prescription for a week, and each day they took it in to receive that day's antibiotics. It was just effectively ticked off on the list until the prescription was finished up. And people often don't finish the prescription, so what's left gets handed on to another member of the family or friend. And so then they can access antibiotics without a prescription, even though officially the system's been tightened up so that they can't. Do people in your culture demand antibiotics? Do they see them as miracle pills? Certainly in some parts of the UK, we find that that's still the case. Increasingly less, or reducingly less. But yeah, you still do get it. And people coming from different cultural backgrounds as well. Sometimes come with different understandings, things that they've grown up with that was just their assumptions that they've always known is suddenly being challenged, and that can be quite difficult for them to see that they will still be safe. Are your dentists skilled at providing the urgent extractions and extirpations? If they haven't done it, if they've just been giving out antibiotics for many years, when someone's come in with toothache, sometimes they've lost those skills. Sometimes they can't do it anymore. And do they need to be reskilled in those circumstances? And one of the things that came out again from my research is that in low and middle income countries in particular, pharmaceutical industry reps can be quite a driving force for dental practices in terms of encouraging them to use more fancy types of antibiotics, or to encourage greater sales of the antibiotics. Obviously not told, we want you to provide more antibiotics, then we can make more profit, although that's clearly what results, but actually saying, we've got a really good antibiotic here that will help many more of your patients, and we think that you should be using it. We don't get that in the UK. I've never known a dental practice have an antibiotic pharmaceutical rep come to the practice and try and encourage us to use antibiotics, because they know that our guidelines are so tight that we wouldn't do that. And you also need to know what guidelines are already available within your country, and why, and what the antibiotic resistance rates are in your country. So when I talked before about erythromycin, In the UK, we don't use erythromycin because we have high levels of resistance. It might be in your country that you use a different antibiotic in a different circumstance for very similar sorts of reasons. But you need to understand why things are being done. Or is it just that someone said, well, that's what the BNF says, and we're based out in some other country a long way away, but it's the best that we have. And actually what's evidence-based in the UK, because the research has been done in the UK, isn't actually evidence-based for another country. You know, when I was out in the Philippines, we were talking about the extent to which UK-based guidance or American-based guidelines are relevant or irrelevant in their situation. So you need to really understand what's going on in your context and then look at what's already available to tackle those issues that you think are key in your context. And only if you need to, develop new approaches. Yeah, there's no point reinventing the wheel if there's a perfectly good wheel out there. So your main thing is to understand, and next to identify gaps, and then to fill the gaps if you need to. So in summary, prevention is better than cure. Antibiotics don't cure toothache. Antibiotics are only indicated if there's a spreading infection, and use your local guidelines for antibiotic type and dose when you're prescribing. Thank you for listening.
Thank you so much, Dr. Wendy, for the amazing webinar. I have to admit that I didn't close my eyes during the webinar. It was really fruitful even for me. Now I would like to see if we have any comments or inquiries. Okay, we have one comment from Juan Carlos. He's thanking you, Doctor, for the webinar.
Thank you.
And I don't see any more comments or questions. I think it's clear. Like everything was really super clear, even for the young students, I believe. But I have one question for me, like a personal question regarding as antibiotic dose. You say that I have to, I mean, dentists have to check the patient every 2-3 days, and once the symptoms or yeah, I mean, dentists can stop the antibiotic after 2-3 days because this cause some uh, may cause some confusion because sometimes we don't know the optimum course of the antibiotic, like for how many days the patient should take the antibiotic. So, is it enough to stop it after 2 or 3 days, or we should wait for maybe 1 week or more days? I don't know.
Okay, so if you've provided the intervention already, so you've removed the source of the infection, then what the study results show you is that even without, once you've removed the source of the infection, the studies show that after 3 days, 99.5% of infections have cleared up. So just keep taking antibiotics for the rest of the week or however long it is only exposing them to a drug that they don't need to be exposed to for longer. And equally, if it hasn't cleared up after 3 days, you want to know if it's getting worse, because actually if it's a resistant infection in there and the antibiotic you've prescribed isn't working, you want to understand why it isn't working.
I got it. Thank you. So there is no need to prolong the course of the antibiotic if I see that.
Yeah.
That's enough. Yeah. Okay. Great. I think that's all for me. Thank you so much. And I have just shared the links of the Scotch dental guidelines and also the British one.
Yes.
And I don't think we have more questions or comments from the viewers. So thank you so much, Dr. Wendy. Thanks all for watching today's webinar, and we hope to see you soon with upcoming ADIS webinars.
Thank you very much for your time.
Goodbye.
Bye-bye.